Hello everyone, and welcome. I'm excited to be here today to talk about key metrics and strategies for optimizing outcomes and resources. This presentation focuses on AI-driven efficiency in cardiac surgery. Over the next few minutes, we'll explore how innovative approaches can improve patient outcomes and make better use of resources. So let's get started. Let's take a closer look at some key outcome measures we use to evaluate quality of care. First, risk-adjusted mortality helps us understand death rates while accounting for patient risk factors, so we can compare hospitals fairly. Next, major complications like atrial fibrillation, infections, acute kidney injury, and stroke are critical indicators of patient safety during and after treatment. Then, we consider 30- and 90-day readmissions, which tell us about the longer-term success and potential issues following a procedure. Failure to rescue is another important metric. It measures how well a hospital can respond to and manage complications once they occur, essentially rescuing patients from potentially fatal events. Finally, we look at the efficiency signal, which compares actual outcomes to what we'd predict based on patient risk. This helps us identify areas where care is exceeding expectations or falls short. All of these measures, clinical outcomes versus expected risk, are interconnected, giving us a comprehensive picture of quality. They show us not just how patients are doing, but how well our systems are performing relative to the complexity of the cases we handle. This aligns with our overall goal of improving patient outcomes through continuous quality improvement. Now, let's look at how we can predict ICU and hospital length of stay. We consider various factors from before, during, and after the surgery, what we call pre-op, intra-op, and post-op factors. By understanding these, we can better anticipate how long a patient might need to stay. We also look at efficiency signals, such as cases where the patient stays longer than expected without complications, which might indicate inefficiencies, or cases where patients are discharged early but don't end up needing readmission, showing effective management. The ultimate goal here is length of stay optimization. That means finding the right balance, reducing unnecessary hospital days without compromising patient safety or outcomes. By doing so, we can improve resource utilization, patient satisfaction, and overall care quality. This ties back to our broader theme of enhancing operational efficiency and patient-centered care throughout the surgical journey. Now, let's take a closer look at some key indicators of resource utilization in our ICU. First, ventilator hours. This metric helps us understand how much our patients rely on ventilatory support, which can vary depending on case complexity and care practices. Next are ICU bed days, giving us a sense of how long patients stay and how efficiently beds are being used. Imaging frequency is also important. It reflects how often diagnostic imaging is ordered, and changes here can signal shifts in clinical decision-making or resource availability. Lab ordering patterns reveal how frequently tests are requested, which can impact both costs and turnaround times. Blood product use is another critical factor, as it directly relates to patient needs and transfusion practices. All of these metrics contribute to what we call the efficiency signal. Specifically, they help us identify variations that can't be explained solely by patient risk factors. When we see unexplained variation, it suggests there might be opportunities to improve practice patterns or resource management. Ultimately, this resource utilization analysis helps us understand where we can optimize care delivery, reduce waste, and ensure that we're providing high-quality care efficiently across the board. Now, let's look at some key strategies for optimizing patient recovery and reducing length of stay. Early extubation is one such approach. By removing the breathing tube sooner, we help patients breathe more comfortably and reduce potential complications. Early ambulation is equally important. It encourages patients to get moving sooner, which can prevent issues like blood clots and promote faster recovery. Restarting beta blockers promptly is another critical point. Maintaining their use helps control heart rate and reduce stress on the heart post-surgery. Additionally, paying close attention to antibiotic duration ensures we're not overusing antibiotics, which can lead to resistance and other issues. We also need to be aware of what we call the efficiency signal, noticeable deviations from the expected pathway that are linked to longer hospital stays or increased complications. Recognizing these signals allows us to intervene early. Lastly, adherence to the care pathway itself is essential. Following established protocols consistently helps us deliver high-quality, efficient care that benefits our patients and streamlines their recovery process. All these elements tie back to our overarching goal: improving outcomes and optimizing resource utilization through coordinated, evidence-based practices. Now, let's take a closer look at some of the key metrics used in our cost-effectiveness analysis. First, we have the cost per complication avoided, which helps us understand how much we're spending to prevent each adverse event. Then, there's the cost per QALY, or quality-adjusted life year, a standard measure to evaluate the value of health interventions by combining quality and quantity of life. Next is the cost per ICU-free day, giving us insight into how efficiently we're reducing ICU stays and associated costs. These metrics are not just numbers, they're used by administrators, especially in value-based care models and bundled payment arrangements, to make informed decisions. Finally, all of this feeds into our cost-effectiveness modeling, which provides a comprehensive way to assess the economic and clinical impact of different interventions, ensuring we're delivering high-value care while managing resources effectively. Let's talk about early deterioration alerts. These are critical because they help us identify patients who might be worsening sooner rather than later. By catching these signs early, we can intervene more effectively and improve patient outcomes. Next, we have discharge readiness prediction. This is all about assessing when a patient is truly ready to leave the hospital. Making accurate predictions here ensures we're optimizing bed utilization without compromising care. Then, there's the focus on identifying patients who don't need ICU-level care. Not every patient requires intensive monitoring, and by recognizing these cases early, we can allocate resources more efficiently and avoid unnecessary ICU admissions. Finally, predictive alerts play a key role in preventing inefficiencies. They serve as proactive notifications that help us streamline workflows, reduce delays, and ensure that patients receive the right level of care at the right time. All these elements tie back to our overall goal: enhancing patient care through smarter, data-driven decision-making. Let's talk about some of the key distinctions that really matter when we're benchmarking performance. First, there's the difference between a surgeon versus another surgeon. It's important to recognize individual skill, experience, and approach, which can vary widely even among specialists. Next, we have unit versus unit comparisons. This means looking at different departments or teams within the same hospital, which can reveal where best practices are happening and where improvements are needed. Then, there's the comparison to hospital versus national benchmarks. Hospital benchmarks give us a localized view, but national benchmarks provide a broader context, helping us understand how we measure up on a larger scale. Now, an important concept here is the efficiency signal. This is what helps us identify high-performing workflows, those processes that consistently deliver better outcomes with less waste. Recognizing these signals allows us to learn and replicate successful practices across the board. All of this ties into benchmarking and understanding performance variation. By comparing data across different levels, surgeons, units, hospitals, and national standards, we can pinpoint where variation exists. And understanding that variation is crucial because it highlights opportunities for improvement, standardization, and ultimately better patient care. Let's talk about recovery speed and how it relates to overall functional status. Faster recovery means patients can return to their daily lives sooner, which is a huge benefit. It's also important to consider the symptom burden. Reducing symptoms quickly can significantly improve patient comfort and satisfaction. Wearables and remote monitoring play a crucial role here. They enable us to keep a close eye on patients outside the clinical setting, providing real-time data that can inform quicker, safer decisions. By integrating these tools, We're redefining efficiency, making recovery not only faster and safer, but also requiring fewer visits to healthcare facilities. This shift truly puts the patient at the center, focusing on their individual needs and experiences. Ultimately, the goal is to deliver care that's more efficient, personalized, and effective, supporting better outcomes with less burden on the patient and the healthcare system alike. Thank you so much for taking the time to be here today. I really appreciate your attention and engagement throughout this presentation. I hope you found the insights and information useful and inspiring. Remember, the ideas we discussed can really make a difference in your work and projects moving forward. If you have any questions or want to explore any topics further, please feel free to reach out. Again, thank you for your time and participation. It's been a pleasure sharing this with you.